Let's look at this case carefully. We have a 70-year-old obese male smoker who presents with ptosis, more on the left side, diplopia, and fatigue. This pattern should immediately make us think about a neuromuscular junction disorder, especially myasthenia gravis. The EMG supports this because repetitive nerve stimulation produces progressively smaller responses. That is called a decremenal response, and it is typical of a myasthenia gravis. He is started on pyridostigmine 60 milligrams 4 times daily, and the next morning he says he feels stronger. But this is where we must be careful. He is now having difficulty swallowing the tablets. He is too breathless to lie flat. He has head drooping and fatigability of the eyes and limbs. These are not minor symptoms. Dysphagia suggests bulbar weakness. Breathlessness on lying flat suggests diaphragmatic or respiratory muscle weakness. Head drop and generalized fatigability suggests worsening generalized disease. So the key issue here is not just diagnosing myasthenia gravis. The key issue is recognizing severe myasthenia with bulbar and respiratory warning signs. Now pause here. The question is, what is the next best step in management? The options are autoantibodies and CT chest, NG tube and double-dose pyridostigmine, oral prednisolone, oral 3,4-diaminopyridine, or intravenous immunoglobulin. Think for a moment before we reveal the answer. The correct answer is option E, intravenous immunoglobulin. This patient has severe myasthenia gravis with bulbar and respiratory involvement. Difficulty swallowing points towards bulbar weakness. Breathlessness when lying flat suggests diaphragmatic weakness or respiratory muscle involvement. Together, these features mean that the patient may be progressing towards myasthenic crisis. In this situation, symptomatic treatment alone is not enough. Pyridostigmine helps neuromuscular transmission, but it does not rapidly control the immune process causing the weakness. Intravenous immunoglobulin is used because it can provide relatively rapid short-term improvement. Plasma exchange is another appropriate urgent option in real clinical practice, but among the options given here, intravenous immunoglobulin is the best answer. Clinically, this patient also needs close respiratory monitoring, vital capacity, oxygenation, swallowing safety, and early ICU involvement if he deteriorates. Now let's understand why the other options are not the best answer. Autoantibodies and CT chest are useful, but they are not urgent treatment. Autoantibodies can support the diagnosis, and CT chest is useful to look for thymoma, but we should not delay treatment in a patient with bulbar and respiratory weakness. Double-dose pyridostigmine is also not the right answer. It is unlikely to be enough in severe disease, and excessive anticholinesterase treatment can worsen secretions and cholinergic side effects. Oral prednisolone is important in the long-term management of myasthenia gravis, but it is not the best immediate step here. Steroids do not act quickly enough, and they can sometimes initially worsen myasthenic weakness. And 3,4-diaminopyridine is used in Lambert-Eaton myasthenic syndrome, not typical myasthenia gravis. So the exam pearl is simple. In myasthenia gravis, dysphagia plus breathlessness or inability to lie flat is an emergency. Think bulbar weakness. Think respiratory muscle weakness. Treat urgently with intravenous immunoglobulin or plasma exchange.